Hi, welcome everyone. So today I'll be presenting a case under the title of Subdural hematoma-induced dyskinesia. This is a 71-year-old female with a past medical history of gastroesophageal reflux disease and major depressive disorder, presenting to the outpatient neurology department with a main complaint of headache since 10 days. She's describing the headache being holocranial, non-radiating, persistent, fluctuating in intensity, but may reach a score of 10, and pressure-like in quality, relieved with ibuprofen, no aggravating factors. This is the first time for the patient to experience such a headache. She denied any previous similar episode, also no personal or family history of migraine. Now, along with the headache, she's also describing daily recurrent falls that has started 1 week, so like shortly after the headache. And because of that, she has become wheelchair bound since 2 days. She says that whenever she tries to walk or stand, she would feel that her entire body is tremulous and she would fall and unable to support herself and walk. There was a third thing that I noted while taking the history the patient did not mention. However, I noticed that she had a combination of different abnormal movements, and when asked about them, she said that they have started with the headache, so like around 10 days ago, but they're not bothering her much like the headache and the falls. Patient denied any focal neurologic deficit in form of visual symptoms, dysarthria, weakness, sensory loss, or any memory issues, seizure-like activities, any systemic symptoms of fever, weight loss, night sweat. There is no recent history of travel or vaccination. She also denied using any new medications beside her regular home medications that she's on them since long time, which are the pantoprazole for her GERD and the escitalopram for her MDD. She's been on those medications for years. There's an important piece of information in the history. The patient had a history of mechanical fall and head trauma a month ago. She presented to the emergency department during that time, and CT head was done, showed possible chronic subdural hematoma, mainly in the left frontal region. During that time, patient did not suffer from any focal neurologic deficit. She did not also lose consciousness during that time. She only had mild headache and pain at the area of the fall that has resolved within a few days. And she's been completely asymptomatic until 10 days when she started to have the headaches and then the falls and the abnormal movement. During that time, the patient was followed up by neurosurgery as well, and they reassured her. So she was completely fine during that time. An examination, patient is alert and oriented. Her GCS is 15 out of 15. Cranial nerves from 1 to 12 are completely fine and intact. She had an intact sensory exam for crude touch, pain, temperature, proprioception, and vibration sense. Her motor power is 5 out of 5 in all of her extremities. She had a normal tone all over, and her reflexes were slightly hyper, +3, but it was negative for Babinski and Hoffman signs. No cerebellar exam, normal cerebellar exam. She had a normal finger nose test, normal heel shin test, no dyskinesia, no intentional tremors as well. It was very difficult to assess her gait fully because she's unable to walk and stand, as I mentioned earlier, but we managed to stand her with the support of 2 people, and she was only taking small steps, and that's all what she was able to do. I also noted, as I mentioned, a combination of different movements. So starting from up down, she had oculoorifacial dyskinesia. She had no head tremors, postural hand tremors. She also had generalized involuntary purposeless movements of the upper and lower extremity that looks very choreiform in nature. So at this point, it was decided to admit the patient in the inpatient neurology department to complete the investigation as a case of acute dyskinesia for further investigations. And during the same time, I ordered autoimmune workup for her, and I also ordered MRI brain with and without contrast that was done at night during the same day. And the on-call doctor was called by radiology and informed about the following results. As you can see, the first one, this is an axial view of T2. You can see that there is a subdural hematoma collection around both cerebral hemispheres. It's hyper intense. And also this is a flare, it's hyperintense. This is T1, it's iso to hypointense. So the final conclusion was subacute subdural hematoma with the biggest diameter measuring around 12 millimeter. And there is sulcal effacement, diffuse sulcal effacement in bilateral hemispheres, as you can see. There was also mild transtentorial herniation. The DWI was negative. There is no evidence of ischemia. And susceptibility artifact also was negative for hemorrhage. Neurosurgery team were consulted to review the patient since she's having a big bleed, big subdural hematoma, and they recommended conservative management because they think she's asymptomatic. But of course, to us neurology, now we know that her symptoms are secondary to the subdural hematoma. So the next day in the morning, patient dropped her GCS to 11. Urgent CT head was performed and it showed. This is again axial view of the brain. You can see that there is a hypodense fluid in the frontal region on top of a hyperdense fluid here. And this is another view. You can see the hypodense fluid. And this is more clear. This is a sagittal view. You can see here the hypodense fluid and here the hyperdense fluid representing acute on top of chronic bleed. And in this time, the biggest width was 15 millimeters. So it has increased compared to the previous exam, which was 12 millimeter. So neurosurgery team were informed about the result. Patient was taken to OT, bilateral burr-hole evacuation was performed, and the post-operative CT shows satisfactory resolution of the subdural hematoma. Of course, there is some residual amount in there, but the overall picture looks good. Patient was seen by neurology during the next day. She's awake, her GCS is 15 out of 15, and all dyskinesia has resolved completely. Starting from the oculoorofacial dyskinesia to the non-headed tremors, to the postural hand tremors, and to the generalized choreiform movement, everything has resolved following the evacuation of the hematoma. So the final diagnosis is subdural hematoma-induced dyskinesia. Before moving on to the discussion, I'd love to show you her CT 1 week post-operatively. You can see that there is a prominent CSF space, but the overall result is actually good, and most of the hematoma was evacuated during that time by the neurosurgeons. And her autoimmune workup and all the other endocrinology workup, like the blood glucose and TSH, everything was negative. Now, when it comes to the chronic subdural hematoma, this is one of the most common neurosurgical conditions. It's very tricky because it has a variable presentation. Sometimes the symptoms can be very nonspecific, like just headache. And even some patients can be completely asymptomatic, while others, they may present with seizures, with memory issues representing subacute and rapidly progressive dementia. Some of them, they can come with the focal neurologic deficit depending on the location of the subdural hematoma, like dysarthria, dysphagia, weakness, sensory problems. The most common etiology is post-traumatic, especially in elderly patients following falls. Other causes include intracranial hypotension, whether it's spontaneous or iatrogenic. Also, patients with coagulopathy may develop subdural hematoma, and patients who are taking certain medications like the antiplatelets and anticoagulation are, of course, more prone to have the subdural hematoma compared to the other patients. Now, when it comes specifically to movement disorders and subdural hematoma, this is actually rare, and some of the described movements in literatures are the choreoathetoid or the choreiform movements, Parkinsonism, rarely catatonia and blepharospasm. Now, for the reported cases and the published cases are mainly Parkinsonism and choreoathetoid, as I mentioned. Usually, they come with subacute to acute, from acute to subacute presentations of these abnormal movements, and usually elderly patients following trauma. And the good thing is that they have a great response following surgical evacuation. So like the choreoathetosis and Parkinsonism would improve completely even without the need to prescribe any medication for following the surgical evacuation. Now, focusing specifically on the reported cases of chorea as a presenting symptom of subdural hematoma, the first case was published in 1977 of a 12-year-old child who's known to have ALL. presented 2 weeks after intrathecal administration of methotrexate with right-sided hemichorea. During that time, investigations were done and the CT showed left-sided hematoma. Surgical evacuation was done for the child and he had a complete resolution of his symptoms. Now, in this schedule, I managed to find 15 published cases of choreiform as a presentation of choreiform movements as a presentation of subdural hematoma. And the 16th case is our case, not published yet. As you can see, most of the cases are elderly patients or adults, except for the first published case, which was a child of 12-year-old of age. And most of the patients, actually all of the patients, they had surgical evacuation and they responded to it completely, most of them, except for one case. I'm going to describe it now. And there was another case who had a recurrence of the symptoms following surgical evacuation. And there was a reason behind that. So now for the second case, this patient, 64-year-old male, presented to the emergency department because of 2 weeks history of headache and memory issues, and his GCS had dropped down there. CT was done, showed subdural hematoma. Patient was managed with surgical evacuation and he was completely asymptomatic and discharged with no choreiform movement, no abnormal movement at that time. Then 3 months following the incident, he presented again, but this time with left lower limb choreiform movement. And again, CT head was repeated, it was negative. EEG was done while the patient was having the movement, also it was negative. So this was a chorioathetoid movement following subdural hematoma and following the evacuation. So because there was no acute subdural hematoma during this time, patient was managed with haloperidol and he had a good response. It wasn't complete, but it was a partial response. The third case, patient with subdural hematoma presenting with, again, chorioathetoid movement. And in this case, patient did not respond completely to surgical evacuation, so haloperidol was added and he had a complete resolution of his symptoms afterwards. Now, what's interesting is this case that was published in 2007 of 71-year-old male who presented with generalized choreiform movement. CT done, he had a bilateral subdural hematoma, and he was managed with surgical evacuation. Patient initially, during the first day, he had a complete response and the entire choreiform movement has been disappeared. But the thing is, he had, again, a recurrence of a generalized choreiform movement. So genetic testing was performed, although he's 71-year-old, and it showed 41 repeats, 41 CAG repeats, suggesting Huntington disease. So this is very interesting for a Huntington disease to appear in a 71-year-old following subdural hematoma. If you would observe here, all the patients with bilateral hematoma, they presented generalized choreiform symptoms. However, patients with unilateral hematoma, some of them, they presented with generalized symptoms, and the others, they presented with unilateral symptoms. Now, the unilateral symptoms, they've been either ipsilateral to the subdural hematoma or contralateral. And the exact mechanism, I'll describe it later. Now, a brief discussion about chorea. So, chorea are irregular. It's considered a hyperkinetic movement, of course. It's irregular, flowing, non-rhythmic, random, purposeless, involuntary movement. Sometimes it can be incorporated into the voluntary actions, especially in the early stages of the disease, giving a bizarre-like movement. The pathology is caused by loss of inhibition on pallidum from the indirect pathway, leading to the disinhibition of direct pathway and hence the hyperkinetic movement. Also, there is excessive dopaminergic activity involved in the pathology. Now, it can be either acquired or inherited, and the causes can be divided into primary or secondary causes. And for the primary, it's either the genetic causes, mainly Huntington disease, or idiopathic. We don't know the cause. And secondary causes could be secondary to vascular event, to infection, to metabolic, or to also autoimmune causes. Now, most common cause in pediatrics is the Sydenham chorea following strep infection. The most common cause in adults is Huntington disease or drug-induced as well. Now, mostly generalized. However, hemichorea is also possible, especially following a vascular event. Now, the mechanism, generally speaking, hemichorea or chorea is a result of a lesion in the basal ganglia in the contralateral side. So, right-sided hemichorea is a result of a lesion in basal ganglia structures on the left side of the cerebral hemisphere, whether it's the caudate, putamen, corona radiata, thalamus, or subthalamic nucleus. Now, to explain that more in detail, so if there is a right-sided subdural hematoma, you'd expect a left-sided hemichorea because the right-sided subdural hematoma would affect the ipsilateral basal ganglia structures, whether it's a caudate, putamen, or whatever, causing left-sided hemichorea. However, we've seen that some patients, they had right-sided subdural hematoma, but they presented with right-sided hemichorea, which means that the structures at the contralateral hemispheres are being involved. So why is that? Now, sometimes with the subdural hematoma, if it is big enough to cause midline shift, this can compress the contralateral structures, which can lead to hemichorea ipsilateral to the subdural hematoma. And other mechanism of injury also, especially if there is a bilateral subdural hematoma or there is a unilateral one, but it's big enough to affect both cerebral hemisphere, to cause a compressive effect on both cerebral hemisphere, it will lead to cerebral hypoperfusion, and the underlying structures of basal ganglia are more prone to ischemic damage compared to the cortex. So that's why they would cause the hemichorea or the choreiform movement. Now, as I described earlier, that movement disorder as a presentation of subdural hematoma, they're generally rare. So why would some patients present with these movements and others, they wouldn't present with these movements at all? It is believed that those patients who present with these abnormal movements, like the choreiform movements, are usually having a preclinical dysfunction of the neuronal network connecting the basal ganglia to the cerebral hemispheres. So that's why they would present with these movements, because already the network interconnection is not working well, and there is a dysfunction. There is not clinically manifested yet, but with the trigger of subdural hematoma, this dysfunction would be more apparent and the abnormal movement would appear. These are my references, and thank you very much. Now, I have a few questions and answers. The first one is an elderly patient presenting with acute onset of right-sided hemichorea hemiballism, localized lesion. A, right thalamus. B, right caudate nucleus. C, left subthalamic nucleus. D, left thalamus. E, left motor cortex. The answer is left subthalamic nucleus. Question 2, what is the most common cause of hemichorea? A, post-infectious. B, vascular event. C, medication-induced. D, autoimmune. E, Huntington disease. The answer is vascular event, B. Question number 3, and the final one. Which of the following is the primary pathology of Huntington's disease? A, increased activity of the direct pathway. B, increased activity of the indirect pathway. C, decreased activity of the direct pathway. D, decreased activity of the indirect pathway. E, inhibition of the direct pathway. The answer is D, decreased activity of the indirect pathway. That's it. Thank you very much.